What are your thoughts on second opinions?
Wonderful. I think everybody should get second opinions. If you're a patient, the more information you have to make a good decision for yourself, the better it is for you.
Welcome to Beyond the Rounds, a Banner Health podcast created by physicians for physicians. In this episode, we have Dr. Dilan Ellegala. He's a neurosurgeon here at Banner University Medical Group. He did his medical school at University of Washington and then went to University of Virginia for his residency, where he did an international year in New Zealand. He then went to Brigham and Women's for a cerebrovascular and skull-based fellowship associated with Harvard. From there, he was also a Harvard clinical instructor. He's done extensive global health work and has been published over 50 times. Since then, he has been in practice for approximately 20 years. Dr. Ellegala, thanks for being on the show.
Thank you for having me. It's a real pleasure.
So, based on all this experience that we just talked about, how has this shaped your current practice of neurosurgery and specifically skull-based surgery?
Well, Nolan, the nice thing is I've been exposed to a wide variety of mentors at different institutions. And so, you learn from the people that came before you. And I've been incredibly fortunate to have had amazing neurosurgical teachers. Some of the best in the country, thankfully. And so what I've seen over my training is the evolution of neurosurgery from trying to have perfect technical results. So if it's taking a tumor out, for example, trying to get every last little bit of that tumor out in the old days when I was first in training, to the evolution to realize that maybe that's not in the patient's best interest. Maybe we leave our patients with a little bit of deficit that really has functional consequences. And so over my career, what I've realized is technical perfection doesn't necessarily translate into a wonderful life for the patient.
And that makes sense. A lot of times we say we don't treat imaging or MRIs or x-rays, we treat patients. Yeah. And it seems like that's the same way with surgery, for example. You don't necessarily treat what you're seeing in the anatomy, you treat the person as a whole.
That's exactly right.
Okay.
And really to get a sense of what is the patient wanting? What's their life like? What do they want as an outcome for their life? Sometimes it is you have to take everything out in order for the patient to survive whatever the pathology is, whatever their disease is. And other times it's taking some of it out, giving them a quality of life, and treating with other means, which we may not have had 25 years ago.
Yeah, that makes sense. You described your experience in New Zealand as part of University of Virginia. Can you talk to us about that?
Yeah, it was just an amazing experience. So as part of our training program at the University of Virginia, we spent a year in Auckland, New Zealand, really as pseudo-attendings, where we were the primary surgeons for most of the cases, enormous caseload of cranial operations, 650 cases during that year, which is quite a lot. And so you really came away from that year comfortable doing cranial neurosurgery. And you came back as the senior resident, chief resident at UVA, and you could step into any operating room and feel like, okay, I can take care of that. I can also get my junior residents out of trouble if they were in it.
Yeah, that's great to know. So from there, you talk a lot now about micro-neurosurgery. Of course, we all think about neurosurgery as removing parts of the skull in these big operations. What exactly is micro-neurosurgery, and what do we need to know about it?
So my fellowship was actually in cerebrovascular skull-based tumors. And you can think of a neurosurgery training, a residency program, as sort of getting your bachelor's degree. And the fellowship is the PhD. That's really the finishing school for neurosurgeons. And there's different fellowships depending on what your interests are, spine, epilepsy, et cetera. Mine was in microvascular neurosurgery, which is learning to operate around the blood vessels in the brain, often little hair-like vessels that are coursing around the brainstem, and learning to operate safely in those areas to fix problems, whether it's taking a tumor out, whether it's fixing an aneurysm, which is a ballooning out of a wall of a blood vessel. And it's really, if you can do that and do it well, I think you're going to be a better any kind of neurosurgeon, meaning, so if you're a tumor surgeon, you're going to be better at taking brain tumors out. You're going to be more delicate with your surgical technique. If If you're an epilepsy surgeon, you're going to be a better epilepsy surgeon. The only thing that it may not affect is if you do spinal fusions, which is a whole different skill set.
Which makes sense. Do you feel like neurosurgery as a whole is moving more to a less invasive standard, or do you feel like the micro-neurosurgery is just advancements in treating specific conditions?
No, I think medicine as a whole is going towards less invasive, and certainly cranial neurosurgery is as well. We're now doing minimally invasive brain surgery. So we used to make, and we still do for some things, we make incisions from ear to ear, large openings of the skull. These days, a lot of these surgeries are replaced with little eyebrow incisions, small keyhole craniotomies the size of $50. And the impact to the patient is huge. So, instead of saying a week in the hospital, they may be able to go home the day after surgery. And their recovery is that much easier. So I think the actual surgery of the cranial, the actual cranial surgery has gotten less invasive, but the future is even more so.
Yeah. It also seems like these patients are going to have a smaller scar, so they look good leaving the hospital,
Absolutely.
Which of course is very important.
It is. Part of it is how quickly can we get our patients back to a normal life?
Agreed.
And I mean, that's the key.
Yeah.
No matter what we might be doing inside the skull or in the brain, the key for the patient is, am I going to get my life back? How quickly can I get it back? And is it a permanent fix?
That makes sense. And so we've talked broadly about for patients. Let's go through a couple maybe more specific cases where we can really dig into how this actually works in practice. So for example, if we start with a 52-year-old male, let's say he comes in, no history of headaches, and he has some vague headache-like symptoms that have been going on for, let's just say 3 to 6 months. He comes into his primary care doctor. His primary care doctor looks at him and says, well, it could be tension headaches, maybe migraines. They try NSAIDs, some lifestyle changes. And then let's just say another few months later, he comes back again. The symptoms are persistent and they're not getting better. What are the things that you are going to look out for that may cue you into something more significant going on?
Yeah, I think part of it is the symptoms you just described. Headaches that have been going on. They're persistent. They're daily. They're continuous. They don't wax and wane potentially. They're not getting better with medical treatment. And maybe a diagnosis hasn't really been made yet. There hasn't been a workup that reveals something. And so anytime, I'm biased. I'm a neurosurgeon. So, I think I look at MRIs of the brain the same way a general practitioner looks at chest x-rays. Mm-hmm. It's a quick test that tells me everything, almost everything that I need to know. Mm-hmm. They're not an expensive study. There's no radiation involved. So it's a non-invasive, fairly easy study to get done and gives peace of mind, but also gets an accurate diagnosis usually.
Absolutely.
And so that's sort of what I would default to.
Yeah. So let's say that were the case. Let's say this PCP says, this is a little funny. I don't really know what's going on here. I'm going to get an MRI of the brain. Maybe even the patient comes to them and says, I just would like an MRI to see what's going on. They get that MRI, and let's say there's a small frontal meningioma there. Mm-hmm. What are the steps towards evaluating that? And then when do you decide that further intervention is needed?
Yeah, good question. So, the biggest thing is, are these symptoms actually related to? So a meningioma is a benign tumor of the lining of the brain, usually grows slowly or doesn't grow at all. It's not an aggressive cancer. It's also one of the most common, it is the most common brain tumor that we find. So in the case of a small meningioma, a benign tumor, the question is, are the symptoms actually coming from this tumor? Or are the symptoms incidental to the tumor? The next question is this tumor growing or is it stable? So if the symptoms are coming from this, there's mass effect, there's pressure on the brain. One option is to go in and take it out. And depending on where in the brain it is, these are, any surgery is still serious, and it is surgery, but often these can be taken out safely and effectively, and the patients do well.
Sounds like the other option, though, is to continue to monitor the progress of this meningioma.
Yep.
Is that something that would require repeat MRIs or further imaging studies?
Yeah, exactly.
Okay.
And it's very reasonable to just watch these. They may never need surgery. And so typically what we say is on a newly diagnosed meningioma or benign tumor like this, get another MRI in a couple of months. If it hasn't changed, get it again in 6 months or a year, and just keep an eye on it.
That makes sense. What symptoms would the patient have that would make you think, okay, this is less of a headache that we can wait on, and instead needs to be a meningioma that we may need to address sooner rather than later?
Yeah, I would say progressively worsening symptoms. So if it's a headaches that are getting worse week by week, month by month, those are rare in a slow-growing tumor or one that's not growing quickly, or if it's something that's already large. And often these tumors present with symptoms when they're larger. And so if you have symptoms that are worsening, or you have neurologic deficits, weakness, trouble talking, numbness, those are reasons to seek care earlier and then to be a little bit more aggressive in our treatment.
And correct me if I'm wrong, but these tumors can get quite large before patients notice them, correct?
Absolutely, yeah. I've had patients with tumors the size of 2 fists together.
I thought the brain was the size of 2 fists together.
Yeah,
or is that just mine?
It almost is, but it's amazing how much your brain and your body can accommodate to things before it becomes truly symptomatic.
Yeah.
So it's
Yeah, that's wild. So you said that the meningioma is the most common brain tumor. If I'm correct, the pituitary tumors are potentially the second most common brain tumors. Just as an aside off of this case, what symptoms do people typically present with in pituitary tumors that would separate them from the headaches that are associated with like meningioma, for example?
Yeah, so pituitary tumors are tumors of the master hormone controller in the body. So the pituitary gland, which sits right behind the eyes in the center. And so that gland controls all the hormones. So tumors of the pituitary often result in endocrine or hormone dysfunction. So patients often complain of feeling tired all the time. They may have trouble with diabetes or sugar control. They may notice that their ring size or shoe size is increasing because of growth hormone secretion from the tumor. There may be a loss of sexual function or libido. And those are all very common symptoms of pituitary tumors. And then the other is loss of vision. So pituitary tumors sit right in the pituitary gland, and tumors of that gland sit right next to the optic nerves. And so patients sometimes complain of blurring of the vision in the outer visual fields.
Interesting. So they don't necessarily get the typical visual field cut that we learn about in medical school. It's more of just this subtle blurring that can occur along with these other symptoms.
Well, usually these are slow growing. Yep. And so by the time the actual visual field cut occurs, patients have gotten used to it. They don't even realize sometimes that their peripheral vision is out.
So let's say their vision is getting bad, and it's actually quite bad. They also are having hormonal issues that have been identified. Is this something that needs to be surgically operated on?
Maybe.
Okay.
A lot of pituitary tumors can be managed with medication. So they can be controlled with the correct medication. So it really requires a team approach of an endocrinologist, an ophthalmologist to make sure and document their vision and if it's improving or worsening. And if it is amenable to medical treatment, that's the first step.
Okay.
Other tumors require surgery. And if we do surgery, this is one of the tumors of the brain that are relatively easier to take out with less complications and less risk.
How does one surgically get to the pituitary? I mean, you can't go through both eyes or to get there.
No, you go through the nose.
Go through the nose. Okay.
Go through the nose. Right. And so if you have a big nose like me, it makes it easy.
I guess I'm in luck too.
And often we do it with ENT surgeons as well.
Okay. That makes total sense. Let's go on to the next case.
Okay.
Let's make this one a little more of a micro case. Let me describe to you a 45-year-old female this time. She is going to do some work around the house. She's reaching overhead. all of a sudden she gets a sharp headache behind her right eye. And it's not necessarily the worst headache of the life that we hear about in medical school, but it's a bad headache. She doesn't usually get headaches like this. So she goes in and she goes to an urgent care. And the urgent care doctor looks at her, neurologic exam is normal, tells her to drink some fluids, maybe gives her some NSAIDs. She goes home. Let's say 6-8 hours later, the headache continues to progress, but this time she's got some soreness down in her neck. She goes into the ED and they do a CT scan and they find that she has an ACA aneurysm. And it's not that abrupt rupture, but it is bleeding. How do you approach this?
So anytime you have an aneurysm, which is a ballooning out of a wall of a blood vessel, the risk is that it can bleed or rupture. And an ACA or anterior cerebral artery aneurysm, if it has bled, the concern is that it'll keep bleeding or it'll bleed again. And so, not to scare the audience, but if you have a ruptured aneurysm, half of patients don't survive to make it into the hospital. Of the half who do survive to make it into the hospital, half don't make it out again in good condition. And so if there's an aneurysm that's diagnosed before it ruptures, the key is to treat it, to fix it. If an aneurysm has ruptured, that's an emergency. The patient has to come into the ICU, and the aneurysm needs to be fixed before it can bleed more.
And what does fixing entail, right? It sounds like, I know that maybe interventional radiology may do things along the lines of this. From a neurosurgical perspective, you guys also do a different approach?
So there's two main approaches to fixing aneurysm. One is through open surgery, where we make a window in the bone, go in, find the aneurysm, and put a metal clip at the base of the aneurysm to prevent blood from going into it. The other approach is to go in through a blood vessel with a catheter, just like you hear about cardiac catheterization. It's basically catheterizing the blood vessels in the brain and then filling the aneurysm with coils to keep blood from going in. Frankly, that is one of the advancements that's been made in neurosurgery over the last 40 years, which is it used to be all open surgery. It's now mostly treating it through the blood vessel, especially with patients whose aneurysms have bled. And what we know is that it's an effective treatment. It's easier on the patient. The recovery is easier. And radiologists do this, interventional neurologists do this, and endovascular neurosurgeons do this. So the nice thing is there's a mixture of specialists who work on these types of problems.
There's a good turf war going on, exactly.
Yeah,
I wouldn't say that, right?
Well, that's the common perception, which is that there is a turf war. But really, my feeling is you have multiple specialists looking at this from their own backgrounds and hopefully working together in collaboration, which means better procedures for the patients, better outcomes for the patients.
Yeah. And I think we find useful tools in different domains.
Absolutely.
And then before you know it, next thing you know, people are using radiofrequency ablation on hearts. Yep. They're using it for back pain. They're using it for whatever they think would logically work in their field. And it makes total sense.
Exactly.
So this patient happened to present with a rupture. Most people are not presenting in that way. Are most people finding these incidentally on MRIs, or are they presenting with headaches, or what's the presentation for an aneurysm that, it didn't just rupture?
Yeah. So often it's just purely incidental. They're getting an MRI for some other reason. They have sinusitis. They have migraine that's unrelated to their aneurysm. And so it is picked up incidentally. Other times, there can be what we call sentinel headaches, headaches that occur before it actually ruptures. Those are rare, but it can occur. And so if an aneurysm is detected incidentally with an MRI or a CAT scan, then the next step is to be evaluated by a specialist who treats aneurysms and to really see, does this one need to be treated or can it be watched?
And is this a risk stratification that occurs where you basically say, what's the risk of doing this versus not doing this?
That's exactly right.
Okay. And is that based on size? Is it based on characteristics? I mean, what's
both and other things. So the size of the aneurysm is the main predictor. The shape of it is another predictor of the risk of rupture. And then there are other factors such as, is there a family history of aneurysm rupture, cerebral aneurysm rupture?
Mm-hmm.
Is the patient a smoker? We know that smoking weakens the blood vessel wall and can make it more likely that an aneurysm either grows or ruptures. Uncontrolled hypertension is another risk factor. So you take all of those risk factors and then you talk to the patient about what do they want for their lives.
What's their risk tolerance? Yeah.
And beyond that, what type of treatment would they like?
Yeah.
Some people do want open surgical clipping because it can be a more permanent fix. You don't have to retreat. Sometimes with endovascular coiling, you have to retreat. But it means a much easier recovery versus open surgery.
Yeah, that totally makes sense. Going back to the sentinel headache that you described, this seems like this is something that is crucial to catch. For the primary care clinicians that we may have listening, how would you differentiate the sentinel headache from maybe more common conditions like tension headaches or migraines? Or is there no good way to do it?
Yeah, that's a good question. I'm not sure that there's a great way to do it. I think what you just described, somebody who has no real history of headaches in the past, often it does present with a pain behind the eye. It can be very sharp and sudden versus just a slow, dull headache. And if the primary care physician is not sure, a relatively safe way to find out is getting an MRA or a magnetic resonance angiography. So there's very little radiation. There's no radiation.
Yeah.
And it gives a good enough picture to exclude an aneurysm.
So for primary care doctors, an MRA versus an MRI without contrast would be optimal. Okay. And would an MRA, for example, would that show if there was a meningioma?
So an MRA alone will not.
Okay.
An MRI will be necessary. So an MRI specifically looks at the blood vessels, but usually they do an MRI, a scout with it that could show something.
Okay, that makes sense. Let's go on to another case. This one a little different. Let's talk about a 45-year-old female. Let's say that she has developed facial pain. And she particularly has pain when she's brushing her teeth. So she went to her dentist. Dentist looks at her, says, taps on her teeth, says that's great. Then she comes back to her primary care doctor who's like, yeah, I don't really know what's going on. So I listened to a podcast with Dr. Ellegala and I thought I should get an MRI of the brain. Gets an MRI and there shows some vascular congestion around the trigeminal nerve. Is this a typical presentation for trigeminal neuralgia, and how neurosurgically do we evaluate this and potentially treat it?
The symptoms you're describing are very typical. So facial pain, usually on one side of the face, worse with stimulation of the nerve. So the trigeminal nerve is the main sensory nerve that takes sensory sensation from the face to your brain. And so if there is pain associated with it, it's often exacerbated by anything that involves facial movement, smiling, brushing your teeth, as you mentioned, just chewing can do it. And often it's excruciating pain. It used to be called the suicide disease before we knew exactly what was causing this, because patients would have this horrible pain and it can be difficult to treat medically. So the typical medical treatment is medication management. Sometimes it's managed well with that. And if it is, then probably nothing further is needed.
Is that something like carbamazepine?
Yeah.
Typically? Okay. So you basically start there, and if that doesn't work, we progress on?
You could add a second medication. Usually you'll try something else as well.
Okay.
And this is usually the primary care doctor or a neurologist who's managing the medication aspect of it. If medication doesn't help, doesn't work, that's usually when I've seen patients getting their MRIs, and it may show a blood vessel next to the trigeminal nerve. Unless you're doing a very specific trigeminal protocol MRI, you may not even see that.
Oh, interesting. So this is good to know. If you're a primary care doc and you see a patient, you want to order that MRI, like definitely specify to the radiologist that you want that protocol.
Exactly. An MRI with trigeminal protocol.
Okay.
And then you get fine cuts through that segment and to see now, even with that, sometimes we don't see tiny blood vessels on that MRI. And so if somebody has these symptoms that are fairly classic, it's great to have a neurosurgical consultation. And then we can talk to the patient about what this could be, even if the MRI is potentially negative. But most of the time, there's something.
So let's say it's on the MRI, it's positive, it's clinical slam dunk for trigeminal neuralgia. What neurosurgical approach do you take to this?
Yeah, so there's two different treatment interventions. One is radiation called gamma knife or stereotactic radiation to the nerve. The good of that is it's not open surgery. The downside is sometimes it can take time for the radiation to take effect.
Okay.
The other downside in my experience is it's a little harder. If the radiation doesn't work, it's harder to operate because there's sometimes scar tissue and adhesions from the radiation. So in my practice, what I tend to recommend is surgery as a first line treatment. And if that doesn't work, there's always radiation afterwards. But surgery involves making a little opening in the skull. The trigeminal nerve is next to the brainstem right behind the ear. And so we make a small opening in the skull here. We go in under the microscope, and it's often very small blood vessels pushing on the trigeminal nerve, and the pulsations of the artery on the nerve is what causes the irritation and the pain.
Interesting. Are those blood vessels important blood vessels, or can you essentially take them out?
If you take them out, you're going to cause a brainstem stroke.
Then let's not do that.
No. Yeah. So this is one of my mentors used to call this tiger country. It's very fine blood vessels all around this area. The brainstem is right there. Most of the cranial nerves, the nerves that work your face, are there, and so you're working in a tiny space with critical structures. But in experienced hands, this is a fairly straightforward surgery.
Experienced, non-shaky hands.
Yeah, exactly.
Yeah. All right, that makes sense. Let's switch speed a little bit. Let's go from cases to myth versus medicine. So there are a lot of people that probably get diagnosed with a brain tumor, and their first thought that comes to their mind is, I'm going to die from this. Is this true?
Well, as we talked about earlier, the number one and number two tumors that we find in patients are actually benign, meningiomas and pituitary tumors. So that's not necessarily true.
And that's about 60% overall, maybe over half of tumors.
Yeah, it's about 30% are meningiomas, and so about 50 maybe.
50. Okay, that makes sense.
The downside is, having said that, downside is that if it is a cancerous tumor, that they're called gliomas, which come from the cells around nerves. The most common type of glioma is a glioblastoma, which is usually fatal.
Okay. So it's more myth than reality.
More myth than reality.
Okay. All right. Let's go on to the next one. This is one that probably you won't worry about too much. But for me, if I were a patient, I may think, okay, so I'm going in for brain surgery. That means they're going to have to shave my head.
I tell everybody they're going to look like me at the end.
Okay. All right. No. All right. So they'd be very handsome.
No, that was true. When I was in training, we used to shave everybody's head. Even if the cranial opening was this big, we would still shave their head. And these days we do a minimal hair shave, so it's just a little strip. If you have hair like yours, you can cover up that little strip until it grows back. And sometimes we don't even have to go behind the hairline. It's in the eyebrow or in a crease in your forehead. Yeah. So that when it heals, you can't even see it.
That makes sense. Good to know. Let's go to the next one. So the next one is, if you have your brain operated on, you may have heard stories where people had brain surgery and they did not come out the same. People often, I'm sure, think when they're going into surgery, I may not be the same ever again. Is this true or not?
I would say in most cases, if everything goes well, patients are the same as when they went in. Now, with more complex tumors that are large or aneurysms that are ruptured, that may not be the case. There may be some damage from the tumor or the aneurysm that's ruptured. Usually the surgery itself shouldn't cause too many changes.
It could be the stroke instead that preceded it, or the rupture that preceded it.
Exactly.
Okay, that makes sense. Let's do another one. So this time, let's focus more on how physicians and maybe medical students are taught. When we come through our training, we believe that if there is a normal neurologic exam, that there's probably no intracranial process going on. Is this true or is this a myth?
In many cases, that can be a myth.
Okay.
So the first case that you mentioned, the patient with progressive, persistent headaches, that was their only symptom. Mm-hmm. And often we see that where neurologically they are completely intact. They just have symptoms, whatever that might be, of headache, dizziness, mm-hmm. facial pain. But neurologically, they have no deficits. They're strong in both arms and both legs. They're walking fine. They're thinking fine. And so certainly if there's a neurologic deficit, that's a clear indication that there might be something going on that needs imaging to look at. Mm-hmm. However, many times that's not the case, and you really have to talk to the patient to figure out what are the symptoms, what have they been, what's been the progression of them.
That makes sense. So it's like in real estate, the three most important things are location, 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 except here the three most important things are history, history, history.
Yeah, I would agree. Yeah, that's true.
Okay, that makes sense. Let's shift gears again this time. We've talked about specific cases. As you've brought up multiple times, systems are important too, and particularly multidisciplinary treatments. We've talked about multidisciplinary treatments for pituitary tumors. In general, a multidisciplinary brain surgery center would look like what in your mind?
That's a good question. What we know now is that it takes a team to take the best care of our patients. And I'll talk about the physician or surgeon team. Mm-hmm. Take the example of a brain tumor. You need an oncologist, a radiation oncologist, often a neurologist, a neurosurgeon, good neuroradiologists, to really look at what's happening with this patient, to have a team-based approach as to what should we do before we even think about surgery. Mm-hmm. What needs to happen is that team needs to talk, go over the films, look at the patient, and have a team-based approach for the continuity of their care. So maybe it is surgery first and then radiation and chemotherapy, or it might just be radiation and no surgery. But you need the expertise of multiple members of the physician and surgeon team. But that's not all. You've got to have great nursing care, and you have to have the ancillary team as well. Physical therapy, often if you present with a neurologic deficit, so let's say you present with trouble walking, you're going to need a good physical therapist, mm-hmm. both before and after surgery.
Because even if you fix that problem with surgery, you still need to retrain the body to then utilize the arms or legs or whatever it is back in a normal way.
Exactly.
Okay.
Exactly.
And then I'd imagine, including all of that team, like you said, nursing, PT, you also want to make sure you have good communication with the primary care doctors and the people that are going to follow this patient for the next, say, 20 years of their life.
Absolutely. And that's why nurse navigators are key. Somebody who has touched the patient and knows the patient, is able to get the patient from one clinical setting to the next and make sure that nothing is dropped.
Okay, that makes sense. And nurse navigators seem to be something that we have at large institutions. It seems like a lot of this weight for physicians, maybe at smaller institutions, is on their own hands, and so it makes it more difficult. Yeah. With that being said, at the large institutions, you have this well-orchestrated, multidisciplinary center. Do you think this actually changes patient outcomes?
Oh, absolutely. No question about it. It changes outcomes in multiple ways. One is I think their patient's care is better. It's an integrated process. Care is faster. Things aren't dropped. Things aren't delayed. But also, anytime, if you are a patient who has a brain tumor, we know that a tumor itself can cause depression. We know that the anxiety of having something like this has effect on our patients from a holistic perspective. It's stressful for them. It's stressful for their families. And so having a team that can also guide the patient and their families through this process is key.
That totally makes sense. Do patients fall through the cracks?
They can.
And so I would imagine if a patient came in and they had something that was detectable early on, just like you think about this in cancer in general, but a brain tumor, you had something early on, that patient fell through the cracks. Next thing you know, the presentation is substantially worse. You have worsening deficits. This has to be something that, we lose sleep over, and we want to find the ways that we can prevent this. Mm-hmm. This is something a multidisciplinary center should be able to help prevent.
Exactly. Yeah. Patients who are lost or fall through the cracks, but also even just delay. Mm-hmm. If you just found out that you have a brain tumor, you don't want to wait 3 weeks to see the specialist.
Yeah. You want to be seen as soon as possible.
As soon as possible. And
otherwise, that's 3 weeks, no sleep.
Exactly.
Yeah.
And once you've seen one doctor, you don't want to wait another week to see the next one. And that's the beauty of a multidisciplinary center, where everybody's talking. The care is happening as quickly as humanly possible.
Yeah, that makes sense. So if we go and talk about getting the care done as soon as possible, what makes the good referral, right? What makes a referral from, say, a primary care doctor who has concern with the patient with a brain tumor? What it goes into the referral, say, types of imaging, lab workup, so that way when the patient gets to you, they're ready to go for whatever treatment they need as soon as possible. Sure. They can get resolution to their problem and make them feel as, the best about it.
The ideal referral has all the imaging in hand, has blood work. If it looks like it could be a metastasis, a tumor that's come from elsewhere in the body, they've had imaging of other areas in their body. But honestly, there is no bad referral. If you're a primary care doctor in the community and you're worried about something neurosurgical, I would rather you just get the patient to us so that we can help you manage the patient. The stress that the patient is feeling, I also would like the primary care doctor or the referring doctor to not feel.
Yeah.
So part of our job is to take the stress off the referring doc.
Mm-hmm.
If you've got something that you think might be neurosurgical, just send it. We'll take care of the rest.
Yeah. I always tell people I do pain management, mm-hmm. and I specifically see neck and back pain. One of my favorite referrals to get is the referral from the primary care doctor who the patient had already started physical therapy. And when they showed up at my office, they say, I'm feeling pretty good.
Yeah.
I'd rather them have that than to instead, like we talk about, fall through the cracks.
Absolutely. Exactly.
Let's switch speeds again. Mm-hmm. Let's go from slow to fast. Okay. Let's talk about some rapid fire questions. First thing, what are your thoughts on second opinions?
Wonderful. I think everybody should get second opinions. If you're a patient, the more information you have to make a good decision for yourself, the better it is for you. And so I actually tell every one of my patients they should get second, third, fourth opinions.
Makes sense.
And travel for care.
Yeah. Go to the doctor that you respect or you've heard good things about.
And that you have a good relationship with.
Yeah, that makes sense. I always tell people if my AC unit went out, I would get multiple opinions and multiple quotes. I think if you're going to have a problem with your own body, multiple opinions is totally worth it. Makes sense. What should your patients ask you?
Lots of things. How many of these have you done? I think a patient should look their surgeon in the eye and say, are you comfortable doing this?
Yeah.
How many of these have you done? But even more than that, it's that vibe you get when you're sitting talking to somebody. Is this somebody that I trust with my life or my family member's life? Is this somebody that's going to take care of me no matter what? Mm-hmm. Is this somebody that I can talk to, that I can ask any question of?
Yeah.
Because a big part of it is, look, brain surgery, even though we've tried to dispel some of the myths, it's still scary.
Yeah.
And you want somebody who's technically outstanding. They're a great surgeon, but somebody who you can relate to and work with on an ongoing basis.
Yeah, that absolutely makes sense. Outside of neurosurgery, if you weren't a neurosurgeon, what would you be doing?
Neurosurgery.
Just maybe spine surgery. Nah. All right. What new tech are you looking forward to?
So there's a couple. We're just about to start using an exoscope.
Okay. Sounds fancy.
It basically we use microscopes for magnification that we look through as you can imagine what you know of microscopes. You look through it. Exoscopes are a digital microscope, so you're looking at a screen and operating with better posture, but also the rest of the team in the OR can see what's happening. And
easier to teach that way, I would imagine.
Easier to teach, and there's new technology that's coming in that could be married to these kinds of devices. I think we can get pathology, histologic diagnosis as we're taking the tumor out.
Okay.
So we can take, instead of a gross total resection, taking what's grossly abnormal, I think we can get to microscopic resection of tumors.
Makes sense. So this would be similar to Mohs surgery for dermatology, where you can take pieces, send it out, see how it looks, and then immediately go back, take more?
Exactly. And kind of Mohs surgery for the brain, but you're not having to send the tissue to the pathologist and wait.
It's happening right there.
It's happening right there.
That's pretty incredible. Is there a case that you still think about?
Yeah, there are.
A lot?
There are cases. Henry Marsh, in his book, Do No Harm, quoted a French physician who said, every surgeon has a little cemetery to which he goes from time to time to pray, a place of pain where he explores the explanation for his failures. And so I think every one of us has cases that we remember, I vividly remember as though it happened yesterday, of where I wasn't perfect. Mm-hmm. And, that is what neurosurgery really is a quest for perfection. Mm-hmm. Perfect surgery, perfect judgment, perfect communication with your patient. And any time where you don't have that, those are the cases you remember and you try to learn from and try to make sure it never happens again.
Yeah. And there's also the cases where you probably feel helpless, right? Where maybe too much has happened, or a stroke was too big, a rupture was too big. Do you encounter those as well?
Usually those kinds of things happen before we ever operate.
Yeah.
And those are the ones where we can't do anything.
Okay. Well, let's wrap it up. Before we leave, I'd like to give a few valuable takeaways to both patients that are listening and to clinicians. So first off, with the patients, I think one of the most obvious things that we talked about, if you have vague symptoms, if you're concerned, new headaches, something isn't right, get an MRI of your brain, right? Would you agree?
Yeah, see your doctor and err on the side of getting some imaging if you can.
And then the second one, brain tumors do not mean you're going to die. Most of them are actually benign and treatable. I say easily in quotes because obviously what you do isn't easy, but they are things that we can treat.
They are, often.
Okay. And then finally, I think this may be the most important out of all of them, is seek a neurosurgeon that actually cares. And if you don't feel like your neurosurgeon is that neurosurgeon, or even if you do, get a second opinion. Would you agree with that?
The more information you have, the better for you.
Okay. And then finally, for clinicians, we're going to have primary care doctors and other clinicians in different specialties listening to this podcast as well. One thing that seems evident to me is that the exam may not show everything, and instead documenting this functional change or clinical change over time may give a better representation of what's going on inside the skull.
Absolutely. Yeah,
okay.
correct.
And then get imaging, like we talked about with patients, ask for that MRI. For clinicians, when something doesn't make sense, we should get imaging.
Yeah, get imaging, or you know what? Just if you think it might be a neurosurgical problem, just refer on, and we're happy to take care of it.
Yeah, and that was actually going to be my final takeaway is, if you're concerned, get the referral to us, get it to people that care, people that you trust and respect, and we'll take care of the rest.
Exactly.
You agree?
Exactly.
Okay. Well, Dr. Ellegala, is there anything else that you would like to talk about today, or anything else that you want to plug before we go?
Nope. I think this is great.
All right. Well, thanks for coming on the show. And as always, we'll see you next time. Thanks for checking out this episode of Beyond the Rounds. As always, we hope you got some clinical insights that you can take back to your patients. If you enjoyed this episode, we encourage you to follow us on YouTube or wherever you get your podcasts. We'll see you next time.